Hi, I'm Jack Cush, Executive Editor of RheumNow.com. It's February 10th, 2017, and this is the RheumNow Week in Review. A few interesting items this week. A report from Dr. Choi and colleagues, great researchers in the area of gout, looked at mortality rates amongst patients with gout, looking at a large cohort over almost a 20-year period. And what they found was that unlike RA, where there's been a closing of the mortality gap, meaning that RA patients who once had an excess amount of mortality related to their inflammation, over time have actually closed that gap and are closer to those who are age matched as far as their mortality statistics who don't have rheumatoid arthritis. But in gout, over nearly 2 decades, the gap that exists with an excess of mortality for those with gout continues to exist, suggesting that we may not be that effective in managing inflammation and managing gout over the long haul. Analysis of patients who have the anti-synthetase syndrome, and specifically those who have the incomplete anti-synthetase syndrome, meaning they don't meet criteria and they don't have the full triad of arthritis, interstitial lung disease, and myositis in association with a myositis-specific antibody like the anti-synthetase antibodies, Jo-1, etc., shows that those who are Jo-1 positive, who are incomplete at the outset, when followed over time, actually do ultimately develop the full triad and the full anti-synthetase syndrome. So there is a predictive value to finding anti-synthetase antibodies in such patients. There's a nice review that you should look at if you're interested in new molecules that are being targeted. Mavrilimumab is a new anti-GM-CSF monoclonal antibody that's been in phase 1, phase 2 trials early. I think it's going to early phase 3 now. A lot of data is accumulated on this monoclonal antibody, and it looks kind of promising. So far, the ACR20 rates are in the 60-70% range with reasonable placebo rates, suggesting that it may very well be a competitor for the future. That's now out as a clinical review. An analysis of autoimmune patients who develop a myeloid neoplasm shows that myeloid neoplasms amongst those with autoimmune disease were more likely in those who are on azathioprine, in fact 7 times more likely on azathioprine, and also more likely in those who received cyclophosphamide, where there was a 3.5-fold increased risk of developing a myeloid neoplasm. We've talked in the past about the potential value of calprotectin as a biomarker in RA and other diseases. As you know, fecal calprotectin is often measured in those with IBD. And it is interesting that this test is often talked about but not clinically available other than as a fecal assay. So researchers actually looked at this in patients with ankylosing spondylitis and spondyloarthropathy. 204 patients were assayed for fecal calprotectin levels, and over 2/3 of them had high levels of fecal calprotectin. More importantly, that when they treated them with TNF inhibitors and they got better, they saw a commensurate decrease in fecal calprotectin levels. That was only seen with TNF inhibitors and not seen with nonsteroidal therapy, suggesting it could be a useful biomarker here. Again, these are just fecal samples that have, and they're looking at their calprotectin levels. Interestingly, in these ankylosing spondylitis patients, only 1.5% developed Crohn's disease. So we've talked in the past about nice studies looking at occult colonic and ileal disease in patients with ankylosing spondylitis, doing camera studies, finding occult inflammation. This is probably yet another way of showing what's going on in the gut in patients with ankylosing spondylitis, making it a center of activity and maybe worth measuring. 2 interesting abstracts about belimumab. Belimumab, there's a lot of data developed, and of course, again, the drug was not developed to treat patients with glomerulonephritis, but looking at all the data from all the RCTs in a meta-analysis of those who had renal disease, sort of promising effects were seen with belimumab. 55% of those who had nephritis actually improved their outcomes when treated with the biologic. 71% improved their proteinuria, and actually renal flare rates were really quite low in those who were on chronic belimumab, only 1.7%, suggesting it may be a tool for those patients. But they really need to do a study targeting specifically those who have 3 and 4 glomerulonephritis with glomerular disease and proliferative, either focal or diffuse proliferative disease. Another study of 839 patients with belimumab revealed that belimumab patients were likely to have responses 13% more than the control patients. That the use of belimumab did result in a delay in flares, but by 51 days, and that they were able to reduce prednisone dose by 6.3% more than those who received placebo, suggesting narrow margins of benefit, in my opinion, and that sort of goes along with some of the overall data about belimumab. So again, it's still looking for a place in the treatment of lupus. To say it should be used in lupus or refractory lupus, I think, isn't really helpful to me. Amongst 331 patients who were followed for their rheumatoid arthritis and how they were treated as far as vaccination, it was shown, and I think this is a German clinic, only half the patients actually received the influenza vaccine, and only 1/3 received vaccination against pneumococcal infections. Again, data that suggests that we're not very good at doing vaccination in our patients, and clearly these vaccinations do benefit. Certainly influenza, the overwhelming evidence benefits our patients. Even pneumococcal population-based study shows it benefits our patients. Diabetics have an increased risk of RA, maybe a 37% increased risk of RA. Interestingly, patients, this risk was decreased by Plaquenil and decreased by abatacept. However, it was not decreased by methotrexate and was actually higher if you were on prednisone and statins. So again, it's known that Plaquenil can decrease the incidence of diabetes. I didn't know about abatacept. You would expect it with prednisone. I didn't expect it with statins. So interesting data. There's a Lancet article this week that looked at the efficacy of methotrexate in patients with moderate to severe plaque psoriasis. Obviously, this has been a long-standing indication to use methotrexate in cutaneous psoriasis-only disease. But most of that was developed on fairly low doses for fairly short periods of time. And this study actually used higher doses of methotrexate administered orally, and they really saw, I thought, fairly modest PASI 75 responses, around 40%. In an accompanying editorial in Lancet, Daphne Gladman pointed out that while this is good, we need longer studies, longer-term studies, maybe combination studies, and maybe head-to-head studies against the new drugs that show much higher PASI 75 responses in the range of 60 to 80% for the newer biologics that target IL-12/23, IL-23 alone, or IL-17. There are obviously 2 and maybe soon a third IL-17 inhibitor to hit the market for psoriasis and psoriatic arthritis patients. A novel subset of peripheral helper T cells has been identified. We know about helper T cells and how they play an important role within the synovium. This particular peripheral helper T cell set is marked by the phenotype of PD1 high, CXCR5 negative, and CD4 positive T cells. And like other Treg cells, it does help B cell activity. But unlike B cell activity, multiple studies with cytometry and transcriptomics and functional assays have shown that you'll get more chemokine receptors being expressed, and these cells probably play an important role in the migration of inflammatory cells to the synovium. So a new cell type, maybe a new target for future therapy. An interesting study in oligoarticular JIA patients. This was done by the Italian investigators in the Printo network, 207 patients with oligoarticular or pauciarticular JIA defined by their onset in the first 6 months. And these patients received somewhere between 230 and 270 intraarticular injections. Half the group only were treated with intra-articular injections. The other half were treated with intra-articular injections plus methotrexate. It is actually shown that methotrexate offered no additional value with the number of patients achieving a remission, I believe, was 32 versus 37%. And the only toxicities that were seen, systemic toxicities that were seen, were in those who received oral methotrexate therapy. This sort of suggests that we might want to rethink how we treat patients with polyarticular disease. Lastly, a nice report from Chet Otis's group at Pittsburgh, where he and his jolly investigators did a nice analysis of the utility of the ANA in patients with the anti-synthetase syndrome, which of course is associated with myositis. They showed that compared to using immunofluorescent assays and looking at just the ANA, those patients who had cytoplasmic staining seemed to correlate very well with the anti-synthetase syndrome. So they selected out 202 patients known to have the anti-synthetase syndrome and looked at the performance characteristics of the ANA. Turns out the ANA was inferior to an ANA with cytoplasmic staining. And that cytoplasmic staining had a greater degree of sensitivity, 72%, specificity, and almost 90%, negative predictive value, 95%, accuracy, 86%, but a modest positive predictive value of 54% in identifying patients with the anti-synthetase syndrome. More importantly, ANA negative patients who had cytoplasmic staining, 82% of these people actually did have, were anti-synthetase antibody positive. So I think a nice clinical tool, if you will. We often see cytoplasmic staining in our patients with ANAs, and what antigens are being identified as sort of quizzical and often undefined. But this may be useful in those patients who have myositis, especially the anti-synthetase type. So that's it for this week at RheumNow.com. Go to the website, find these links, read on more. Have a great weekend, and we'll see you next week at RheumNow.com. We'll be covering the RWCS meeting in Maui next week. Watch for our tweets and videos and live updates. Have a great week.